1 minute. One minute. Yeah, now start.
Good morning and good afternoon, everyone. On behalf of 𝐷 Foundation and Center for Law and Policy Affairs, I welcome you all in today's webinar on health system responses to COVID-19, learning across Bangladesh and Vietnam. I am Dr. Rumana Haq, Executive Director of 𝐷 Foundation, and I have a number of distinguished guests with me today. Professor Dr. Mahmudur Rahman, former Director of the Institute of Epidemiology, Disease Control and Research and National Influenza Center in Bangladesh. Dr. Pham Quang Thai, Member of Rapid Response Information Team, National Steering Committee for COVID-19 Prevention and Control, Vietnam. Dr. 𝐀𝐑𝐊 𝐅𝐨𝐻, Head of the Nafil Center for International Health and Development, University of Leeds. Dr. Nitish Devnath, Team Leader, Fleming Fund Project, Bangladesh. We also have Dr. Khalida Islam, former Director, Primary Healthcare, Ministry of Health and Family Welfare. Dr. Jahangir Khan, Senior Health Economist, Liverpool School of Tropical Medicine, United Kingdom. And Advocate Sayyid Mahbubul Alam Tahin, Secretary, Center for Law and Policy Affairs. We all know that COVID-19 pandemic has spreaded very fast globally. And as of today, around 10.42 million COVID patients have been identified globally. Many developing and also developed countries have been exposed to COVID-19, and the health systems and the weaknesses of health systems have been revealed in many countries, including Bangladesh. But we have also seen that a number of countries are really doing very well in containing COVID-19. For example, Vietnam. So we have arranged this webinar today to share the ideas, views, and lessons learned that how Vietnam and many other countries have contained COVID more efficiently compared to some of the low and middle income countries. We may say that Bangladesh has done taken some very good initiatives, but in many instances we could have done better. So I would not take much of the introduction. I would directly go to our first presenter. He is renowned, and we don't need any introduction, but I would again say that Professor Dr. Mahmudur Rahman, our first presenter today, he served as the director of IEDCR, and he devoted 33 years to epidemiologic and public health research and surveillance of communicable and non-communicable diseases and public health policies in Bangladesh and in many other countries. Currently, Professor Mahmudur Rahman is serving as consultant in the program for emerging infectious disease division, ICDDRB, and he is the chair of Southeast Asia Regional Certification Commission for Polio Eradication, and he is member of a number of other chairs, number of other committees, and chairing many committees now. So I will request Professor Mahmudur Rahman to give us the idea that how Bangladesh has done since the first case of COVID has been identified in March 8th, or even before that, when COVID was identified in China in late December. Have we done what we should have done? Have we utilized the time properly to prepare ourselves? And how we are responding to combating COVID-19, and your reflection of the COVID management in Bangladesh. Over to you, Professor Mahmudur Rahman.
Thank you very much, Professor Rumana and all other. First of all, I would like to thank for actually organizing this webinar and also inviting me to speak on behalf of our country. So I will go to the presentation, but when I'm preparing this, I would like to also tell you that I was leading the pandemic when it occurred in 2009 on H1N1. So I was very much there in that. So that will also have some reflection on my presentation today. So as you have mentioned that what went well and what have been better, what could have been better in response to Bangladesh, that I will be focusing on, but I will also give you some idea about what is the current status. So I will make my presentation restricted to all 4 items, but I would like to bring in a little bit of the global strategy also, which will make you understand that what should be the standard in a country like us. So when we go to the situation of Bangladesh, as you have mentioned, that first case reported on 8th of March, and subsequently now we have a total reported cases of 133,978 with total reported deaths of 1,695. But I would also like to tell you that these are all passive reporting. We don't have an active surveillance system to understand what is happening, but these are all over the country it is coming. And we are testing those, and as people who are actually coming for testing, those are reported as positive cases. So when we plot this into different graphs, you can see that the graph which I am showing on the upper left, this is showing about the total number of new cases detected per week, and that gives a better understanding of the situation. So if you see that from the first day, it is on the rise, actually going up still now. But if you look down a little bit on the next graph, you can see that this is the percentage change. So percentage change means the change that is happening, number of cases that is coming up every week. That is showing a little bit of downward trend, but unless it goes to negative, we won't see the benefit what is coming up. So that is what, even from the passive reporting, this is the one we are seeing, which can tell what is happening in our country. And if you look into the positivity rate also, the number of tests done and number of tests getting positive, this also initially was around 12 and subsequently now for the last few weeks, what we see that it is actually hovering around 20 to 21, 22, around that level, and that is maintaining for some time there. If you look into the death, this is case fatality rate, obviously. This is also not a crude estimate, where it is also seen that this is down. And this might happen due to the improvement of the management of the cases, obviously, and a lot of other things may also take part here. And if you look into the interventions that has been undertaken so far in Bangladesh, just to make you understand a little bit, government has undertaken quite early, starting from 22nd January, all these interventions where they have gone for international travel quarantine, school closure, cancellation of public events, workplace closure, restriction on international travel. So these are the things which has happened over the time. And still now there are interventions, but this has been relaxed a little bit now. At least people are not allowed to remain outdoor from 6 p.m. to 8 p.m. to 6 a.m. Stores are kept open for a short period of time. But I will also make a comment later, but here also I would like to mention that if stores are kept open for a longer period, then there might be less crowding. That is sometimes people want to keep it restricted, but opening it for longer duration also helps sometimes. And also some of the international flights, those were closed, but starting gradually, and even the domestic flights are also starting gradually. Even the inter-district transportation has started also with precautionary measure that has to be taken. So as I mentioned that if you have to understand where we have to be there, we need to understand a little bit of the global strategy to respond to COVID-19. And I will just give you the understanding where it has to be. And countries like developing countries are doing that, mobilize all sectors and communities for hand hygiene, respiratory etiquette, and individual level physical distancing, and also prevent community transmission by testing, isolating all cases, providing them with appropriate care, contact tracing, and quarantine. These are the standard has to be there in every country. And also the most important, another issue is the infection prevention control measures, which is not only at the population level, but even in the health, that hospitals and other places, which is also very important. and also to reduce mortality by clinical care of the affected by COVID-19, ensuring continuity of essential health and social services, protecting frontline workers and vulnerable population, which is the area. We have seen in SARS coronavirus also, MERS coronavirus, that this type of viruses spreads very quickly. And we have seen in South Korea in 2000, when it came MERS coronavirus 2012, one case gave rise to 186 cases. So, and also the other point which you might think that why it is so important now, I will bring it up later, that develop safe and effective vaccines and therapeutics that can be delivered at scale and based on need. This is very much important, and this is also on the top at the international level. The countries should get prepared if the vaccine comes, how they will have to use that, and all this preparedness has to be there. So if I go down to talk a little bit on that, where country could do better. And as you see that all of government engagement, initially what we have seen in Bangladesh, that health sector was actually responding to, except only one sector which came forward, the disaster management, when the institutional quarantine has started. But all other governments were not that much engaged at the beginning, but gradually over time, our Honorable Prime Minister's office got involved, and almost other departments are also coming together, joining hands in responding to all these containment measures. And also we couldn't, as you will hear, we will hear from Vietnam also, screening at the point of entry as per the IHR requirement was not totally followed very much at that time. And I think that was our initial stage, that as we say that in an outbreak situation or any pandemic situation, everybody will have to be aggressive if we really want to contain it well. And at the beginning, if you could get it done well at that point, we could contain it. And I would like to say that no country can stop pandemic, but we could try to delay it as much as possible until some measures comes up, like drug or any vaccine comes up. So that has to be tracked in a way so that we can slow the process. That is the target actually for a pandemic situation. And when we talk about the institutional quarantine as per IHR guideline was also not up to the mark here in this country. That's the reason we couldn't continue at some time. We couldn't do that very much well. So there were some institutional quarantine, but not at the way it should be. So there was also some sort of gap we see initially, where we could get benefit much if we could do better there. Regarding the contact tracing, isolation, quarantine, that was also another, as I said, that if we don't go for a whole of a government approach, this contact tracing cannot be done by one institution for the whole country, which initially was tried. And that was also another part where we could do much better if we could delegate it at a lower level to the administrative authorities to do the contact tracing at their level. So that was one issue which still country is struggling on, the contact tracing, isolation and quarantine, because there are two types of isolation. One is institutional, is also home isolation. So these are where, and quarantine is also another issue which people sometimes don't understand much about it, the importance of that. And engagement of more laboratories at the beginning. Initially, only one laboratory was trying to cope up with the situation. Actually, there were other laboratories even in the country which could be engaged at that time. Currently, we have 66 laboratories working, but we started with only one laboratory, though at that time, some laboratories had the capacity to do the testing. Subsequently, we have developed our capacity. And preparedness in terms of logistics was a huge issue, because a lot of countries, most of the countries face problem about the PPE. Still, the countries are facing problem in there. And that was a part of the preparedness. If this could have been done earlier, at least some buffer stock could be there, which could be used. But gradually, countries are trying to overcome that in terms of the PPEs mostly. In terms of the hospital preparedness for management of COVID-19 patients, triaging was an important issue which couldn't be done very well. Some hospitals they did, but as we have overcrowding in our country, as you know, we have a large population. So that is a huge challenge also for us in terms of infection prevention control and also ICU facilities. So these are still gap, and that was from the very beginning, and that happened, though some of the hospitals have got empty the beds, but those hospitals do not have the ICU facilities, though. So patients do not like to go to the hospitals because if they need it, they won't get that. So that is another area where could do better. And also the health training of the healthcare workers, which is, from our experience, we know that unless we do it all over the year, during the pandemic, we will not be able to cope up with. So this preparedness from the very beginning, all the time, would be necessary, which also we have experienced in 2009, as I told, that we had a lot of preparedness in the whole country, and we prepared for avian influenza, then the H1N1 came in. So we had a lot of preparedness there. And also the identification of risk communication focal point is an important issue, as you know. Otherwise, there is a lot of thing can happen, and which is also people can get the wrong message if this is not done well, handled well. So this is about my presentation. I will stop here. I think wait for other questions must come up and we can answer. Thank you very much.
Thank you, Professor Mahmood Rahman. That was excellent presentation, and you showed that where we really did well, and there are many instances where we could have done better, especially increasing the number of testing centers and also procuring the PPE and in many other fronts. So thank you so much for your very insightful presentation. So I would like to go to our next presenter. We all know that Vietnam has done really well in containing COVID-19, and so far what we say in Bangladesh is that there is no death yet in Vietnam. So I would like to know more from Dr. Pham Quang Thai, who is the member of Rapid Response Information Team, National Steering Committee for COVID-19 Prevention and Control. He has 20 years working experience with infectious disease and EPI in the National Institute of Hygiene and Epidemiology in Hanoi. So I hand over to Dr. Thai now. Dr. Thai, would you please share your experience with the participants today?
Thank you. So I will share my screen. Yeah, you see that?
Yes, we can see it. Thank
Okay.
you.
So in my presentation, I talk a bit about the current situation in Vietnam and what control measure we use so far to prevent COVID-19, and some lesson learned and some future priority. So we are now living in the world with more than 10 million of cases and more than 500,000 of deaths. We learned that quite early. We learned that from something happened in China. Something happened very early in December of 2019. We hear about some disease very similar to SARS that happened in China, and that we are afraid of, because we know if SARS coming back, we have problem, because in 2003 we already have SARS, and we have to defend for the country for more than 40 days, 45 days actually, for SARS in 2003. And we take that into a lot of experience dealing with SARS in that time. And we learn about the pathogen, we learn about host, we learn about environment change during the outbreak in order to mitigate the disease. And we learn about the things in China. You know, every day we hear news from China, what happened in China and how they deal with the outbreak. And at that time, there is no case in Vietnam. but we start to prepare. We start to form the steering committee that comprise of 23 different ministry, and we know that anytime the new case file in Vietnam, we have to start the steering committee right away and all of the preparation for that. So far, you can see in that map that we have 355 cases until now. And 70% of those is imported from outside. 29.9% is a community case, and it is now 75 days. 75 days we don't have any community case, and all current case is imported from outside. When we keep sending airplane out to bring Vietnamese people back to country. That is a case distribution by day. So we don't have that much of case to share with you. Not many case. Not many case. And most of the case we find is from foreign country, from the different airplane that bring the patient back. But there is one thing that we want to share here, that is number of people have to spend time in quarantine. There are people coming back from China. They go right away to quarantine. Sometimes they cross the border, and if they cross the border illegally, and when they come back to their community, the people from community can report them to the health station, and they will be gathered into the health facility, in the quarantine health facility, in order to be quarantined for at least 14 days with 2 times testing. The first testing is the time they enter the quarantine center, and the last testing is 1 day before they can be discharged from the quarantine center. So we have 2 times testing for all coming back from the high risk area like China, or coming back from abroad with different airplane. The problem that we find so far is 63.47% of patients is no symptom, because we find them quite early. Maybe we, based on the contact, based on the epidemiology factor that they are coming back from the high risk area. So we test them, and we find from those 63% is no symptom. And after sending them to the hospital, only 20% more develop symptoms. So at the end of all, about 41% is still no symptom. That is a problem, because the COVID-19 have too many people, too many patients, no symptom. So they are only infected, but they are no symptom. They still can transmit the disease, and we have the evidence to say so. That is the reason why we have to lock down some commune, some area for at least 14 days, just because they have the community transmission. So the first commune that we are locking down is Sơn Lô. Is one commune very close to the capital city. And then after that, we have another 2, 3, 4, 5, 6, 7, and 8 different location that we have community transmission, and we lock down the whole area. And the biggest area that we lock down is the one biggest hospital in Vietnam. And in that hospital, we lock down more than 4,500 people inside, and also we do the contact tracing for almost 100,000 people related to that hospital, and we test them all. So some of the factors that contribute to what so far succeed is the rapid response. We have the evidence-based surveillance active, and we hear information from China and from country around, and we define every country that have more than 500 cases as high risk area at that time. That is the reason why any people coming back from high risk area have to come into the quarantine center and have tests there and stay there for at least 14 days. And we stopped the national event and festival very early. At the end of January, we start to stop all of that event, and we try to find all the case, and we try to not only based on the WHO guideline, but based on the evidence that we have. And very clear leadership, as I mentioned, 23 different ministries have to work under the steering committee, and all of the ministry have to have at least one people at least to join the committee in order to coordinate all of the activity from any decision made from government and from the committee, the steering committee. Another things, Ministry of Health play a critical role in order to prepare all of the evidence to government, and also we have the different pillar to have detection of case, to have isolation, to have tracing case, and do surveillance. So you can see from here, compulsory quarantine for everyone entering from China from very early time is 25 of January, and for all people arriving from elsewhere from 7th of March 2020, it is quite strict and quite, some people complain about this. Some people still say that Vietnam react too strictly, too strong, something like this, because we suspend visa exemption and restrict entry quite early. Even the Korea still blame us at that time because we closed the visa for many Koreans to come and work in Vietnam at that time. We know that it is quite strict, but it is the only way that have Vietnam, because at that time we have very limit of PPE, limit of tests, limit of many things. And even for ventilations, even for ICU unit in the hospital, own limit. And we know that if we have that much of case like Bangladesh have, we may have the same number of deaths. But so far, we don't have any death. That is the graph showing that milestone of the time. And you can see at the end of March, there is 73 flights that have COVID-19 patients. That is the reason why we have to close all of the flight, and we chase all of the passengers from the flight that have COVID-19 patients. And from those 73 flights, we have 34 flights that have to quarantine whole passenger. I mean, everyone in the flight have to go to quarantine. And then after that, all the flight after 17 of March have to quarantine in the quarantine center without any exception. Yep. And we also have many different guidelines for medical treatment, and also for quarantine, for contact tracing, for social distancing. So far, we have more than 300 documents to have different level to react with COVID-19. And local community health center can provide all of the primary healthcare service in Vietnam. And in Vietnam, we have more than 11,000 of community health center that join into the COVID-19's control. And there is one thing that I would like to share here is the work of media. Media has played a very critical role in all of that activity, because they transfer the right information to all people. So all information about the disease, about the quarantine, about the contact tracing, about the important of own that control have to transfer directly to the people. And even the government changed the ringtone of waiting cone into the message that everyone make a cone, we hear the message, and the message change by day. Every day we have a new thing, we have a new policy or whatever, it will change the waiting tone so that everyone can hear something new from the government. And very important, that transparent information on positive case is very important. Some people complain that it violates the privacy, but we keep the name disappear. We don't show the name, but all information about the case will be transferred to the people. A number of cases today, from where they got the disease and why it spread and so on. We send that to all. So that is very, very transparent, and there is no hidden. There is no case that not public. And a lot of infographic. It's in the televisions. The information about the disease had been announced, I think, for every hour. They can hear at least something, or they can read something running on the TV, telling about the COVID-19, telling about the danger of the disease and how to protect themselves. One other thing contribute to the success of this policy is tests. We might have lack of medical equipment, we may have lack of personal protective equipment and so on, but for the tests we have our own tests. Vietnam produced the Vietnamese test, and there is more than 120 different lab facility that can run COVID-19 test, and all that test is real-time RT-PCR test. So it's very accurate. And so far we do nearly 400,000 of tests. And when we calculate the number of positive per test, is nearly 1 positive per 1,000 tests. It means a lot of tests, because almost every contact, every close contact, every one at risk will be tested, and at least 2 times. And for those who come to the hospital, they can have many tests afterwards. We also use technology to help. We use new app to help self-report, and also provide the epidemic report and information to people. And the app can also help contact tracing in terms of the people self-report, and also report the infected case if they think that is infected case. And so far, using the app, we also find some case from community from that way. It means the case coming back from the border illegally, they come to community, but the neighbor, they know that people coming back from the border, they report that to the system, and the health doctor, the medical doctor come and ask the people to the quarantine center and test them all. That is something that Vietnam's different with other. That is, we not only test for the close contact, we not only ask the close contact to be in quarantine, but we also ask the one who contact with the close contact to be quarantined at home, which means the route 2 contact, and also route 3 contact and route 4 contact also being asked to stay home, waiting for the test result from the previous one. So previous round will be test, and when they have test result negative, the second round, the third round, the fourth round can release. But if any of them got positive, then the second round will be treated as the first round, and all of those have to go and test in the quarantine center. So with that much of testing and quarantine, we hope that we can catch the speed of spread of the virus, and so far we succeed by that. And treatment is free of charge, and other thing, testing also free of charge, and no service test, only testing provided by the government and all free. and people come to the quarantine center also free of charge. So far, more than 300,000 people has spent time in quarantine center, and all of them has free food, free place to stay, and also free treatment if they develop any other disease. So lesson learned, we keep learning. That is one of the lessons. We learn from other. We learn from country nearby. We learn from the treatment from outside. We learn from study. The other thing is transparencies. The only information has to show to other these transparencies. How many go to quarantine, how many test positive, how to treat people, and so on. And we, based on cell capacity, for example, testing and treatment, we not based on only one guideline. We can change the guideline accordingly based on the chain of the world. And also we have a very strong surveillance network. I mentioned 63 provinces, 700 of districts, and more than 11,000 of communes all join into that network. So some future priority. We are now working on the vaccine development, and the vaccine have been tested in animal model with a very good result. And now we are waiting for the second phase. I hope that we can make something from that vaccine. The other things, testing technique will be more quick and more precise. And contact tracing and information app also developed quite well. And we have now more than half of the people in the city now install the app and ready to work. And other thing I want to say, the open science. Data is open for science, open for scientists in Vietnam to working on. So data from case, data from treatment, data from contact tracing is open for scientists, and a different group of scientists have distribute of the data in order to analyze and also building the model to predict the workload, predict the burden of the disease, and also predict how much we need if we have a new case imported. So that's all for my presentation. Thank you for your attention.
Thank you so much, Dr. Thai. I'm sure that everyone who has joined the webinar has really learned quite a lot from your insightful presentation. And you clearly showed the leadership from Vietnam team, and the transparency, accountability, rapid response, surveillance system, and many other factors that really help to achieve the success in Vietnam. I would like to take the opportunity to thank everyone who has joined the webinar today from different parts of the country, and also from UK and other countries. So I can see Professor T. Mensah, Professor Sohail Reza Chaudhary, Bas C. Ebonso, and many other names. I can't read all, but thank you so much for joining, and please stay with us. We'll come back to you for your reflection as well. So at this time, I would like to request Dr. Nitish Devnath, team leader, Fleming Fund Project Bangladesh, and who is actively working to promote One Health approach in Bangladesh. So Professor Dr. Nitish Devnath, please tell us about your ideas and views that how Bangladesh, through the multi-sectoral collaboration, through the One Health approach, or the whole society approach, how we can move ahead, taking all the different stakeholders to contain COVID-19, and how we can manage the situation better. So over to you, Dr. Nitish Devnath.
Thank you, Professor Mana, and thank you very much for inviting me to this particular webinar. And it is quite an interesting. Also, I was hearing from two predecessors. They nicely presented some experiences both from Bangladesh and Vietnam. What I will be doing now here in Bangladesh context, as well as little bit of sharing of our experience in One Health, and am I right or wrong? I don't know. Share.
Not yet.
Why is it not coming?
Share your screen.
Your screen, but
You have to click on the, when you share the screen, you will say several boxes. You have to click on the box you want to.
yeah, I am sharing, but this is not coming. I don't know why.
Whether your presentation is with anybody else?
Yeah, I've given it to them, but
is it not coming?
Yeah, I think they just click the PowerPoint icon, so it will work. Click the PowerPoint icon. Yeah.
Okay, it's coming now.
is it there now?
Yes, we can see now.
Okay. Okay, sorry for disturbing this. Well, I will be talking mainly on 3 points. One, what is One Health and why is One Health? And how this One Health is relevant to our current COVID-19 pandemics and how is it operationalizing. So you all know that One Health is basically based on the understanding that human health, animal health, and environmental health are very interlinked, and we have to look in a very holistic way. But more importantly, One Health is also a strong message to all that it allows you to harnessing the creative power of diversity. And you remember, at the very beginning of this century, there was a call, what we call One World, One Health, and that is known as the Manhattan Principle. And the main message was there to recognize the essential link between human, domestic animal, wildlife health, and their food supplies and economies and biodiversities. These are all very interlinked. That is what is the One Health, a holistic approach. And this is what, is One Health is not only the health or human health issue. It is basically a human-animal environmental interface. It promotes collaboration, communication, food safety, research, and many other things. But why is One Health? If you look at this slide, since beginning of our 1980s to as on today, we have been experiencing the emergence of large number of viral as well as bacterial new diseases that has not been recorded in the past. That includes HIV, Ebola, and H1N1, Nipah, and Ebola. And now we are facing what we call the COVID-19. Most importantly, there are 3 SARS viruses that we have already encountered. One is the SARS, which had a 2002, 2003. Then we have MERS coronavirus, and now we are having the SARS coronavirus type 2. And you can see these all new diseases in a very unusual way spreading all over the world, not in one particular country. And it works like that. One example from the Ebola, that it comes from the disease like wildlife, like bat, and then it might have an intermediate host, and then it transmits to the human being, and then human to human transmission. And that is what is the one concept of the origin of the virus. And we can stop it in the origin, then we are very successful. If we cannot, that we are in trouble. And this is one of the quotations that I would like to share with you. Why is it happening so frequently nowadays? Over the last 3 decades or 4 decades, every 1 year we are having one new diseases. Why? And that is the comment, I am quoting from a book they call Spillover, an animal infection and the new pandemic. We invade tropical forests and other wildlands which harbor so many species of animal and plant, and within those theater, many unknown viruses comes up, and they don't get the host to attack, and we are the only most important one that we often get it. And perhaps that is what is happening. How is it relevant to our present situation? Look at this slide, we have been having these pandemics over the last several centuries, and now in this century, we have got quite a good number of pandemics type potential viruses. And since 2009, as on today, we had several pandemics, including the H1N1, the one we had in the SARS, that one we had the so-called Ebola, and what we have the similarities that we have, every 100 years we are getting one, and the cases that it is killed a total of 10,000 cases in 1720 in France, and all these similarities, what does it indicate? That it is happening every year. But what we have not learned, the most common thing that the outbreaks all over this is that it is either a virus or a bacteria, and there is an association between animal. And that has been seen in bubonic plague, even in cholera. That's also we have seen that it has been contaminated with water and the food. And the Spanish flu is with avian influenza. And now we are having COVID-19, which is caused by consuming the infected wild animal meat. This is what is the assumption people are talking about. And when you talk about the operationalization of One Health, this is one of the One Health leader, global leader, he said, these questions, he said, preparation, positioning, elimination, planning, and winning the war. So he posed a question, are we losing the battles or winning the war? And for that he said, the Nipah, avian influenza, pandemic, all these things when came up, scientific community giving the voice that whether we are prepared to face a new pandemic. It is not when, it is not if it will come, but it is when it's coming. Now it is there. And in every war, you need to have a position. Here I have seen in the Vietnamese colleagues sharing that, they have really limited the transmission at the local level. And that is the trigger point. I am posing this question whether we are really following the strategy. And we have two options. Either we will eliminate this virus, that could be a one target, or we will mitigate. If it is a mitigation, then we are in trouble, or we have to target for the elimination. Are we really targeting the elimination? If not, then we are in trouble. And the planning, do we have a proper planning or not? And that planning got to be based on scientific information and public health intelligence. And winning the war, as we have already heard that, three most important steps: test, trace, and quarantine. And that can be expedited by digital contact tracing and social measures, all these things. Are we really following this or not? With this question, we operationalize One Health in three sectors. One, what we call the whole of a society movement. Another is a whole of a government approach that Professor Mahmoud Rahman has already said. Another one is the active engagement of the global community. If we see about the whole of a society movement, we always ask to engage not only the professional people, but the community as such. Those who are the victims, those are the most worst sufferer, whether we have been able to engage them or not. That is most important. And all other components of the society, those who are affected with the pandemic, got to be involved. One of the lessons that we learned from the Ebola there, initially we thought it is not coming or it will not affect us much, or even it has come, it will go away. That was the lesson that we learned from Ebola. But the biggest mistake that occurred, that was being recognized by the experts during the whole outbreak, that, we have not really engaged, we have only asked what to do, what not to do. But the programs were not, no effort was made to ensure the engagement of the community and earning the trust of the community. That lesson, I don't know whether we have followed in this case. And that is one question, and we are yet to really understand this thing, and perhaps we have to follow this one. And whole of a government approach, that is, we have been advocating for a long time in Bangladesh. For that thing, we initially started with the donor-driven, but then government engagement was very good, and we engaged a lot of professional people, social scientists to come to this umbrella. We secured the government budget, even if it is a minimum. We were sustainably working with the capacity building, human health, or other things. All these things we are learning, and One Health movement was very vibrant in Bangladesh. But the question is, when this COVID-19 came up, have we seen that, the first 1,000 cases to only 76 days, that is more than a little bit more than 2 months. Then the second 100,000 cases recorded only within 11 days. And the third 1,000 cases we got on 4 days. And the fourth 100 cases within 2 days. And all these things happening, if you have learned the lesson from the Vietnam, right at the very beginning, they focused to stop the community transmission, and they were very successful. But then, in other countries, including some of the most developed countries, this is a worse experience that we got, and we have not been very careful about this thing. This is one of the important, thing that, this, what we call the flight. And our Vietnamese colleagues already showed that how strongly they control the flights that are coming within in the country. And this is how, this is a picture we are showing there. And one day, how much of flights are traveling, and it is not that Bangladesh is out of that scene. So with these things, we want to engage that, a whole of a government approach. And I am posing this question, maybe we don't know whether we are successful in controlling that. And the next one is the engagement of the global community, particularly when you talk about the One Health. And our perception is that this time also, our global leaders were not very careful at the initial phase to respond to things. The collaboration, cooperation, integration, and transparency, these were all at the very initial stage were not that prominent. But what we can see now that G20 Extraordinary Leaders Summit, they are now proclaiming that, we have to work very together, and they are asking to push money as US $5 trillion for the global economy. They are also asking that the developing countries and the least developed countries will also be coming here. One of the important things in the global community fight, the Director General WHO mentioned that, fight very strongly like hell. And that is no excuse, no regrets, and we have to go for fighting against this virus. The second is to unite. No country can solve this crisis alone. We have to bring all countries together. And third is the ignite, the industrial mind. And for that, ignite for the innovation of the vaccine, therapeutics, and global to ignite together. And that is what his call is. I wonder whether we have done these things or not. And with these things, I am going to summarize my presentation there. Human beings are the ultimate cause of the pandemics. Deforestation, agriculture intensification, urbanization, these are all the main potential pathogens that really affect and causing the pandemic. Whole human travel, germs travel. When people travel, germs travel. When germs travel, pandemic becomes possible. And a lot of unexpected things. It is happening already. It started with a pre-symptomatic. We got the symptomatic case. Now we are talking about the asymptomatic case. So pre-symptomatic symptomatic, and all these unexpected things are happening. And we must all hang together. We cannot remain separated. And if we remain separated, then we will all hang separately. And the last, not the most, I think the most important one is the pandemic is giving us a wake-up call to unambiguously fight to interrupt the spreads of the virus, consciously also prepare for the future pandemics, because this is only the one coronavirus that we are facing. There are other potential pandemic threats are already within our world planet. So we have to also prepare for the future. And I would like to conclude with this one. His Ghosn is a war strategician from China, and he said, every battle is won or lost before even it is fought. So the preparation and also what we call positioning and elimination and planning and winning the war with proper strategies based on the science. That's what we need to look at. And One Health movement is one of the most crucial approach and strategies for our future. And that is what I wanted to share with all of you. And thank you very much. Here is the end of my presentation. Thank you.
Thank you so much for your excellent presentation. We are a bit behind of time, so I request now Dr. 𝐀𝐑𝐊 𝐅𝐨𝐬𝐬, who is head of the Nuffield Center for International Health and Development at the University of Leeds, UK. 𝐀𝐀𝐊 has extensive experience leading collaborative research with partners from Asia, including Vietnam, India, Bangladesh, Nepal, and Africa, for example, Nigeria, Ghana, and Tanzania. Dr. 𝐀𝐀𝐊 is also an elected member of the board of the Health Systems Global. So I request Dr. 𝐀𝐀𝐊 now to give his reflection of the presentations he has already heard and how Bangladesh or any low-income country can move ahead with immediate, medium, and long-term goal. So over to you, Dr. 𝐀𝐀𝐊.
Thank you very much, Dr. Romana. It's a pleasure to be with you. Many thanks for inviting me to join this distinguished panel. I should probably start with a caveat that I'm not a virologist or indeed epidemiologist. So my expertise is very much in health policy and systems. So I'll be speaking about COVID-19 and national health systems responses from the systems perspective rather than the COVID perspective so far. So I would like to start with a bit of background that health systems are increasingly kind of understood as being very complex phenomena. So they involve different levels, different subsystems, different types of services, preventive, promotive, curative, the plethora of actors and stakeholders who are engaged in very complex and dynamic relationships. And all of that revolves around people, or ideally should revolve around people. And because health systems are complex, they actually mean different things to different people. It's like that well-known tale of the elephant where the different health systems professionals, they see health systems as primarily being about finance, or about human resource management, or about supplies, or indeed service delivery. So just from that perspective, I think it is important to always see the bigger picture, see the wood behind the trees. So bringing it into the kind of the context of COVID, I think the brilliant presentations from all previous speakers have emphasized that key approaches to addressing the COVID-19 epidemic are revolving around four kind of issues. First is the clear leadership in ensuring the rapid response to the epidemic. Second is the continuous communication within the kind of response community as well as with others. Third is robust test, track, and trace system, which is leading to sort of quarantine measures and safe isolation and so on. And last but not least, the whole host of context-specific packages related to prevention. Yeah, for example, physical distancing, the sort of wearing masks in public places, travel restrictions, various variations of lockdowns, and so on. And having said that, I think there are also very common growing recognition that issues of equity are particularly compromised. There is growing body of evidence of indicating that there are increasing kind of rates of, for example, domestic violence during lockdowns. There are clear indications of excess deaths, so deaths due to other conditions because of lockdowns from COVID, as well as kind of implications on wider societal, economic, and welfare issues too. So a couple of issues from the health systems perspective, that there is no one size fits for all approach. So different approaches can be equally effective or ineffective. And as we have heard, for example, from Vietnam, strict lockdowns, very rapid response has been very effective in Vietnamese context. There are also other indications from other countries, for example, South Korea, where the country did not go into lockdown at all. But that approach has been complemented with kind of robust test, track, and trace system, which has actually did the job quite well. So in a way, any approaches need to be cognizant of the local context. And the other important point that I would like to make is availability of resources is not always a key to success. As we have seen with examples of number of European and North American countries, in particular UK, US, for example, Spain and Italy, wealthy countries are not immune to epidemics. And indeed, actually, in many ways, response to COVID-19 has been the worst in industrialized world. So just from that perspective, I think it's not about the amount of resources, but how the resources are actually used within the national health systems. So fundamentally, I think health systems responses to COVID-19 are very much about ensuring resilience to the COVID-19 as a shock to the health system. And ensuring resilience is, well, there is a number of frameworks emerging from the literature, but the most established framework interprets health systems resilience is very much about three types of capacities and strategies. So it's about absorbing, it's about adapting, and it's about transforming the health system in response to a particular shock. I would like to pause at this point with the resilience, and I will come back to it later in the talk. But what I would like to emphasize now is the balance between what is emerging in the literature, which is called hardware and the software elements of the health system. And in many ways, I think the attention has been very much on the left-hand side of the screen, on the hardware. Yeah, understandably, emphasis was on ensuring there available staff and appropriate expertise, ensuring reliable information, personal protective equipment, supplies, testing kits, intensive care units and ventilators. So all the hardware, tangible elements of the health systems that you can see. However, far less attention has been paid in many contexts to the software elements of the health system. Things like trust and confidence from the general public to the wider health system. Things like shared values of equity, justice, social inclusion. Continuous communication has been very much approached from the hardware. And for example, media has played an instrumental role in Vietnam and many other countries. But communication from the perspective of establishing the good rapport, a good dialogue has not been really approached from that angle either. And I think effective leadership and governance, I would also kind of mention these under the software, although it bridges the kind of divide and shows the complementarity between the hardware and the software elements of the health system. The other message I would like to kind of reflect on is the importance of the wider context. Context is a very complex issue. Various people just draw a box around everything and call it a context. In my experience and collaborative research, we find it helpful to break down the context into something tangible and a bit more kind of visible. You can see on this slide various elements of the context, which actually emphasize the configuration, the organization of the health system. And what is important is not just reflect on the elements of the context, but also take this as a message that transferability of lessons between the different countries needs to be cognizant of the unique country context. For example, strict lockdowns and non-anonymized or relatively less anonymized tracing that has been effective in Vietnam may not always be appropriate to every single context. Whereas the unique features of the Bangladeshi context include pluralism of the service provision and enhanced role of a very wide network of NGOs that can be really leveraged upon in trace and track and trace systems. The private labs, for example, can be potentially leveraged upon the multi-sectoral opportunities in Bangladesh, for example, include potential involvement of garment industry in addressing the shortages of personal protective equipment, masks, and so on. And the external influences from the fairly kind of large donor and external partners sector can provide an opportunity to leverage further resources into the health sector. So reflecting on kind of health systems responses in the short, medium, and long term, I would actually bring back the resilience as a concept. And in addition to absorbing, I think in the short term, the response is very much reacting on the spot to the epidemic. In the medium term, it's very much about adapting and containing, and in the longer term, it's actually transforming the health system and learning the lessons for the longer term. So in the short term, I think we've already pretty much globally past that stage, and I think on reflection, it's very much about immediate response, strong leadership, robust surveillance system, and immediate containment. In the medium term, it's that introduction and sustaining of the test, track, and trace system, regular communication to build trust, to build the dialogue with communities and ensure their compliance with prescribed measures, preventive measures, equity and inclusion. I think important not to lose off the radar at this point. And in the longer term, it's very much kind of transforming systems and processes to what different people call new normal. So living with the epidemic until the vaccines will be available and affordable as well. But also reflecting on successes and failures of the different national health systems as well as globally. And equally importantly, planning for future similar events. As the previous speaker has brilliantly illustrated that actually this is a no one-off event. It's a very much a trend in the longer term. So before closing, I would like to flag up two specific resources that might be helpful. First is the data repository from Johns Hopkins University that has the global repository on COVID-19 as well as the individual countries, I think very well represented. And understandably, they have got the US focus too. And the second is the resource that has been hosted at the London School of Economics. It's not quite the health systems responses to COVID-19, but it's the next best thing. So it's the community and institutional long-term responses to COVID-19. And in the top left corner of the slide, you can see the different country reports as well as the international cross-country comparisons. Incidentally, neither Bangladesh nor Vietnam are actually listed in their country reports, which indeed represents an opportunity to share the experience and sort of even reflections from this webinar. That is something that might be useful to review in the longer term. And that's it from me. Thank you very much. And back to you, Professor Romana, at this point.
Thank you so much, Dr. Toli, for your reflection on the overall situation and the presentations from the distinguished presenters. So thank you so much for agreeing to join the webinar and being with us. I request you to stay a bit more. We are a bit running late, but I request all the panelists to be with us. So at this time, I will request if anyone has any question to our distinguished panelists, please raise your hand. You can see that in your Zoom link, you can there is a icon called raise hand, so you can use that and raise your hand, and I will take your question. So please raise your hand, and I will take a few questions. Before that, I already have received some question over Facebook and from some other colleagues that during the COVID-19, we are compromising the service for general patients, for non-COVID patients. So I would like to request Dr. Khalida Islam to reflect a bit more on that what is the scenario for the non-COVID patients, especially those who are suffering from different chronic conditions. So where will they go during this COVID period, and what is the system response for that? So over to you, Dr. Khalida. Please just try to complete in 4 minutes. And Dr. Khalida Islam, she was a former director of primary health care, Ministry of Health and Family Welfare. She is now working as an independent consultant, and she was the member of mid-term review of the 4th health sector program recently. So over to you, Dr. Khalida.
Thank you so much, Professor Romana. I'll be very brief, focusing on non-communicable disease care provision only. In the month of May, WHO conducted a quick assessment in 155 countries and came regarding NCD service provision, and came out with the report that showed NCD service provision is severely disrupted. So I picked up the points from that report and tried to contextualize absolutely in Bangladesh context. From patients' perspective, it is fear of contacting COVID and also to get stigmatized. We had travel restriction, public transport lockdown, reduction in income, which is very important because we know 67% of our health cost is from out of pocket. So patients were not willing to go outside seek care for non-communicable disease. If we look at the provider's perspective, most importantly, insufficient PPE. Moreover, health workforce infected as of June 15, around 3,500 health workforce were infected, which demoralized them in providing healthcare. They became afraid. Among other issues, we have seen in 27th June in the newspaper that 67% of healthcare facilities, indoor facilities, beds are not utilized. It is because the healthcare provision is disrupted. I know the non-communicable disease department of Ministry of Health, they have to cut down their budget and support NCD activities. Stock out because of lockdown. The fields were deprived of continuous supply of medicine, test kits, etc. And overall health system was disrupted. Ministry has taken lots of initiatives. All of us are aware, hotline, telemedicine, supply of things, and they involve public, private facilities as well. It's introduced online courses and regarding translated many IC materials, tried to strengthen the health system overall. But the many websites were developed, many materials were developed. Developing those materials is not enough. What we feel, we have to utilize those websites. Through these websites, we have to reach to the community, especially to our health workforce, online training, online orientation, providing them, keeping them updated with information. Through them to reach to the community is important. We need to develop the database of the NCD patient and involve the healthcare providers so that they can, frontline healthcare providers, so that they can follow up the frontline healthcare providers, and maybe we can support them with minimum 3 months drug training on routine checkup and encourage home-based care. As soon as one is enlisted, we have to train them how to check blood pressure, how to do blood sugar test, etc. Most importantly, we have to accept this new normal, and we have to accept this situation. We have to be familiarize ourselves with the digital health, utilizing these websites. We need to communicate to our healthcare providers routinely. Through the healthcare providers, we have to reach to the community people as well. And we have to accept the situation. We have to move forward. Thank you so much.
Thank you. Thank you, Dr. Khalida Islam. I can see that Professor Zahidul Qayyum, he has raised his hand. So Professor Zahidul Qayyum, please give your questions to the panelists.
Yes. Yeah, my question is to the panelists. Also, thank you, Professor Ruman, and thank you everybody in the panel. And it was really interesting discussion. And unfortunately, I missed the connection for some time and then got back again. But again, when I joined, I could see the last presentation and also by Tolly. But my general kind of question to the panelist is the health system responsiveness. I mean, we from an international experience, and there are kind of quite interesting experience from all over the world that which country has really responded well, and see that some of the best health system didn't also perform very well, and some of the countries' weakest health system were also struggling but could do something. So my point is like what you were, Professor Talib, you were mentioning that the short run and the long run, medium term and the long run. Just a few things that how far the system itself and how far the system within the other, because this is a very kind of another sector that is responsible, including the political commitment, was really useful from the experience we have seen from other countries, and has really helped that some countries perform better than others in the short run and the medium term. And then, you know, when we're talking about the long term, it really comes down to some of the things which these weaker health systems are lacking all the time. So we do think that the COVID system will kind of make them respond to things that will help improve in the long run. I'm sorry, I'm taking much time to say the question, but I think that's what my aim is, to see that why it is some of the good health system didn't really come do something very well, which was supposed to do in the short term or even the medium term. And we're expecting something to be done in the long term. And how would you say that? What are the other things that will be very important so they can really do something in the long run? Just to summarize that.
Thank you. So I'll come to the panelists, but I want to give the floor to Professor Sohail Choudhury. Professor Sohail Choudhury, I can see you are here. So, Professor Choudhury, any reflection from your side?
Thank you very much for giving me the opportunity to discuss. Actually, I'm not an expert on this. I'm an epidemiologist.
So we can't hear you properly. If you just come a bit closer.
Hello?
It's better.
Okay. It was a very interesting session, and it's a very good opportunity to hear from various experts in this field. And I really enjoyed the comparison between the steps taken by Vietnam and Bangladesh. And we understand that we actually missed a lot of trains. But at this stage, what should be the most good step for us? I would like to hear from Professor Mahmoud Rahman. I'm actually working with him closely, but I'd like to hear from his views about the steps that we need to take at that current situation in Bangladesh. Thank you.
Thank you. We have another distinguished guest with us, Dr. Nauzia. Dr. Nauzia, if I request you to give your reflection. Dr. Nauzia.
Thank you very much for inviting me. It's a pleasure to be here, and I have a very good experience, like Sohail Bhai said, that we learned from Vietnam. But it's very disappointing for our countries that we are not taking lessons from other countries. I'm so sorry, I'm just criticizing myself, like our country. And we have got limited resources, but I think we should learn from other countries and see what other countries to contain this infection, because this is very important, because our curve is now rising, and you know, like our everything is open, all the economy for living and for life, we have opened everything, all the businesses are open, but we have to take care of this, because I know Mahmoud Rahman sir, I've seen him after a long time, and I'm very happy to see him. And I also want to listen from Mahmoud Rahman sir that what we should do now to contain the infection, because I'm really worried about my country, and I'm really worried what will happen to us if we do not take care at this moment. So thank you very much, Rumana and Tahin, for arranging such a fruitful discussion and for inviting us. We have learned a lot, and we'll also continue to learn a lot. Thank you very much.
Thank you. Just to add, Dr. Nauzia Yasma, she is the head of Public Health Department in State University, and Professor Sohail Reza Chaudhary, he is one of the directors in National Heart Foundation, Bangladesh. So I will go back to the panelists before opening up the floor. So I will start with Professor Mahmoud Rahman. Please, if you just give your reflection on the questions that they raised.
Okay, thank you very much for raising this question. The answers are not very easy. What I would say in short, that we need to take evidence-based decision. Unless we depend on the evidence and take a proper decision, we will not be able to succeed. So what we can do now, still now, we can have a system in place where we can have the real data, and depending on that, we can take decision on that. So that will help us in containing the disease well. That is most important thing. And also, there are few issues like where we have to go for mitigation measures, where we have to go for containment measures. Those concepts has to be applied as needed, and only then we'll be able to succeed. Another question came up actually, that why some countries having capacities could not do well having those capacities. I would say that you need champions in those areas. If you don't take the decision right in time, as you have seen in the case of Vietnam, I can tell about 2009, we in Bangladesh, we are one of the 5 countries did very well, and we took decision very early at the pandemic period, and that helps you a lot, and that gives benefit to the countries. And also you can save people's lives. Over. With short answer, this is the one I can give. Over.
Dr. Tolib Mirzoev, if you want to reflect on the questions already raised.
Well, thank you very much. I think if we knew the answers to those questions, we would have address the epidemic already. I think these are really important and pertinent questions. And also, as Professor Rahman was speaking, I was ticking off the different sort of items from my potential answers. So absolutely agree with champions, absolutely agree with evidence-informed decisions. I think there is a lot of lessons from Bangladesh that many other countries can learn too. And in Bangladesh, I think there's been quite a remarkable improvement in health at a relatively low cost. And that is something that I think is important to build upon. And more specifically, bringing it into the COVID situation, I think one aspect that I would like to raise is thriving and vibrant civil society organizations and NGO sector. I think that is providing a really solid advantage for the national health system to leverage this huge potential, but also to engage with the civil society organizations in order to build trust, to build confidence, or rather further strengthen the trust and confidence, and also ultimately ensure the public's compliance as much as it is feasible. Because that was also one of the key failures of the UK and US systems in particular, kind of fairly limited trust in the government and the kind of establishment, so to speak, from the public and the general kind of communities. That's all for me. Back to you, Professor Romana.
Thank you. So we received one of the questions that despite this COVID-19 this year, the health sector budget in Bangladesh also remained quite low. And historically, the health sector always remained less prioritized, in the national budget in Bangladesh. So we have with us Dr. Jahangir Khan, Senior Health Economist from Liverpool School of Tropical Medicine. Dr. Jahangir, I would like to hear from you that what is your reflection about this year's budget and overall priority of health sector in the national budget for the last couple of years, which is quite low. So what's your reflection, Dr. Jahangir?
Thank you, Professor Romana. I like to start with some figures which will help us to have a better understanding. I'm going to share my screen now. Can you see the slides?
Yes, we can.
Okay, thank you. So I give some reflection from this year's budget, and then I will connect it with previous years with Vietnam and some other countries in our region. We see that $71,000 million was allocated for health for total budget in Bangladesh this year, which was announced in 11th June. And the health budget was $3.7 million. And one important part to think about it is 58% of the total budget is on National Revenue Board control tax based. So we have a budget deficit, which has been discussed a lot, how the rest of the budget plan will be covered from which sources. So anyway, we can limit ourselves within the health budget and see how it looks like. So last few years, since 2016, the health budget has been increasing every year, the nominal money value. And in this year, in addition to the health budget, which is 29.2 crore Bangladeshi taka, there is additionally we see that 10,000 crore or 1,250,000 million US dollar has been allocated for health for COVID-19 issue. But it is not specific to health. It's not in Ministry of Health budget, rather it is a reserve fund which can be used for this purpose. And we know that health budget is not limited within the Ministry of Health and Family Welfare. There are some other ministries which get health budget as well, like local government, defense, home ministry, and so forth, for taking care of health of specific groups of people, or sometimes the general people have access to those facilities as well. So we see it has been increasing every year in terms of absolute money, But if we connect it with as a share of total budget, then we see it is around 5% almost every year. It was in 2016-17, it was 5.1, and then it increased up to 5.2 again. Now it is 5.1 this year. So even if Bangladesh is doing a lot good in terms of economy, graduating from low income to lower middle income country, but still the health budget is within a frame. I mean, we don't see much commitment considering this percentage. I just like to compare with Vietnam in this context. We see that in Bangladesh, $36.3 per person is spent for health, while the corresponding figure in Vietnam is $130, which is, I mean, not at all comparable to any extent. And next figure is another interesting one for government commitment. It is 9.5% of the general government expenditure is on health. In Bangladesh, it is only 3%, so 1/3 of Vietnam. And there are some other figures also shows similar, I mean, low commitment from the government to health. And there is reflected later on out-of-pocket expenditure, which is 74% currently in Bangladesh. Out of 100 taka, we spend 74 taka from our own pocket, and which is 45% in Vietnam. So, I mean, this scenario in Bangladesh is not a new one. It is a development from the history. And if we compare with some other countries in the region, then we see that Bangladesh has the lowest domestic general government health expenditure of general government total health expenditure. And we see that Maldives has highest among these countries. But if we compare with the welfare states, I like to compare with a very well-organized health system, like in Sweden, United Kingdom, Canada, Australia, it is 18 to 19% of the government expenditure is on health. So we have a huge gap here, any countries which I am comparing. If we go to the current situation, just for giving a reflection that if we want to do a test, COVID-19 test in a government facility, it is free so far, but the government announced that 200 taka and 500 taka will be applied soon, and it will not be free anymore. And this is from government facility, and the private facility is 3,500 to 5,000 taka per test. And just many of our people are dependent on those private facilities because the government facility is not enough, not adequate for providing services to all. And when we are going to the private facilities, then common nature is that if one is infected in the family or one have the symptom in the family, we need to test other individuals also within the same family. And then if we have 4 members in the family, it is up to 20,000 taka only for the test of COVID-19. And this is the reflection we see that out-of-pocket payments and government commitment is a huge gap between those two. We see how it looks like in this region for out-of-pocket payments in other countries. I mean, Sri Lanka, Nepal, Pakistan, India has more than 50% or 50% or more, but still Bangladesh is the highest. Maldives and Bhutan have successfully reduced out-of-pocket payments a lot. So that is the reflection. I said, one interesting thing I want to just very quickly show here, that you'll see that 2.99 or 3% of domestic general government health expenditure of total government expenditure in Bangladesh. But when we see the budget, it is 5.1% of total budget. So even if we see in the budget how it is planned, but when it is spent, the money is spent, then we see that even the commitment is much lower. And in this 5.1%, we have only Ministry of Health's money. But in this 3% or 2.99%, we have Ministry of Health and also other ministries who are spending money on health. So Ministry of Health share is even lower than 3% in that case. So the commitment from the government, there's a large scope for improving or increasing the commitment of the government for health budget. And very painful part, I would say that even during Corona period, what we started to observe from December, and still government had a lot of time to give more, plan the budget differently for addressing COVID, but we don't see huge, in terms of health, we don't see a lot of commitment there. So it's a very conventional budget compared to other years, less reflection on COVID, except this 10,000 crore taka, which is, we don't know if how it will be spent, it's not clear, but it is reserved there. And another key message is actual expenditure on health appears to be much lower than the committed one in the budget. We also see that despite rapid economic development in the country, the health budget is still poor. It is not giving reflection. We are rich in terms of money, but we are not rich in terms of our health budget or health money. And our reliance on private sector, it is continuing, it is increasingly, it is increasing all the time. And in the COVID situation, we see the same thing. Government is putting people on the private sector a lot, and private sector is on high cost also. Government is not, giving enough money to the private sector for providing service to the people. That could be another way to manage the things. The 10,000 crore taka, or that is reserved, can we suggest for that COVID-19 test could be free for many people or poor people in the country or middle class people also in the country? ICU equipment could be invested on ICU equipment, quarantine isolation, safety of physician, nurses. Many physicians and nurses and other health staffs are dying. And it is really, we need to take care of those professionals a lot, in addition to all people in the country. And mental health situation, it is horrible in the country. And we don't see much even advertisement about how to tackle the mental health issue in the national TV and different TV channels and so forth. Government could spend some money there as well. And I saw some gaps in services from the presentation of Dr. Khalida Islam, and of course they have already identified gaps in services where this reserve money could be spent. I'm hoping that government will be more devoted to health sector, and that's what I was supposed to say. Thank you very much.
Thank you, Dr. Jahangir. I can see one hand, Dr. Basi. Dr. Basi from University of Leeds. If you have any question, any comment?
Yes, just thank you very much to the presenters for very insightful presentations that give us a comparative analysis of what has been done in the two countries. Can I ask directly to Dr. Tai regarding the presentation from Vietnam? Thank you very much for emphasizing, you mentioned during your presentation, the role that digital health app played in your case reporting. What wasn't really clear was the proportion of cases of the total that were then reported through those apps. Yeah, so that's question one. Question two, you presented a multi-level contact tracing and quarantine model. Well, I think there were even 4 levels. of contact tracing. Just to help us in the West, who is involved in the contact tracing? Usually, or in the beginning of COVID, most contact tracing and testing were done mainly by health staff, but increasingly the general community is also now being drawn in. What is the picture in Vietnam? Who is involved in the contact tracing of this multi-4-level contact tracing and quarantine model? Thank you.
So thank you for the question. Yeah, it's quite tough question for me. Firstly, about the app that I mentioned, there is actually two different apps. One is reporting app. It means there is the patient can self-reporting using the app, and also the neighbor. I mean the neighbor, the one who live with the patient, or the family member can also report the case, because if the case not using smartphone, they cannot report it. But if they meet someone who has smartphone, and the one who has smartphone can have report that case to the health system. So people from health system can make contact with can contact the case, and then send a response team to bring them to the quarantine center for testing and for treatment. And so far, when you ask how many people have been found using the app, actually not a clear number of cases have been found by the app, because we have many different means that help the contact tracing team to find a case. Not only the app, but the app can provide the information very quick, and then we have to confirm, not using the app, but using the phone, or using a rapid response team to send to the place to confirm. So the app only sometimes only trigger the searching process, not using only the app in case of finding the case. That is about the app. And so far, the number of people who use app it's quite a lot. I don't have the actual number today, but someday before, I already see the number of people who already installed the app and already active is more than 10 million of active user already use the app. About your second question, the second question is about could you repeat a bit relate to the second question you mentioned with me?
Yeah, you had mentioned a multi-level contact tracing.
Okay, so multi-level contact tracing, not so contact tracer cannot be the only epidemiologist. We have a team here. We call rapid response information response team. That information response team not have some people from epidemiology, but many other coming from IT, coming from different group that help us to organize the programs. Before we gather all information, we transfer that information to different level. So people from district, people from commune also join into the tracing. When they receive the information, they have to come and to confirm about the case. And when they confirm about the case, they can ask the voluntaries show up in quarantine center. But if the people not voluntarily show up in the quarantine center, the rapid response team will come to them with people from the local government, police, or someone else, in order to ask the people, the high risk people, to go to the quarantine center. So contact tracing is not the work from people in the health system. It is a comprised work of IT, of communications people, and different sector in order to help find the case as quick as possible. Because sometimes we cannot find the information from the register system. People coming from outside to Vietnam, they spread to many different provinces very quick. So at that time, maybe we need to use a Facebook, we use a WhatsApp, we use a whatever app in order to find the people. And when we find them, we will send rapid response team to the place that they are staying to find a case. So contact tracing is not the work of only the epidemiologists, but there is a very big team and a whole network of preventive medicines working on that.
Thank you.
Thank you. Thank you. Before concluding, I will go to one of our organizers today from Center for Law and Policy Affairs, Soyod Mahbub Alam Tahin. He's the Director of Center for Law and Policy Affairs. But before going to that, Tahin Bhai, just give me a minute. So I will go to all the panelists and give them just 1 minute to say the few words if they want to from their experience again for Bangladesh, if they want something to suggest. So I will start with Professor Mahmudur Rahman. So if you have any last comment, just 1 minute, please.
Yeah, thank you very much. Actually, I have already mentioned about two issues about the evidence-based and also the champion, but I would like to add one more thing. If, in our context, we need to actually strengthen our coordination among different ministries, which we see a little bit of gap there. So that will be also very helpful for our to take it forward. Over.
Thank you. Dr. Nitish Devnath.
Well, from my side, I will also echo with Professor Mahmoud Rahman. In this war, I think coordination is the most important. And as a One Health proponent, I always advocate the whole of a government and whole of a society movement. And particularly our society remains only on the direction from the top, but engagement of the community is very poor here. And I would strongly urge the leaders and commanders in this particular battle, they should engage the community. Otherwise, this war would be very difficult for us. And particularly when you think about a country like Bangladesh, where so many people, the population size as well as country size. And I think other than the government, society engagement is very important. Thank you.
Thank you. Dr. Thai?
So thank you for the suggestion. So government in Vietnam, we have something that people only believe only when they trust. People only follow when they trust, and people only work when they really believe that is work. So that's why in my presentation I talk about transparency, and we have updated almost everything, and we not hide anything for the whole time. And people also learn that every day we publish information about outside, especially from the neighbor, China. So we're not based on the afraid of people to ask people to work, but we tell the people that is our life, that is our fate if we are not follow the instruction from the government. And people understand that. I think it's very important to have to do the health education. So everyone, for every single minute they are meeting, every meeting they talk about COVID. Until now, people still talk about COVID like, what's the weather like today? So they say, what the COVID like today? And because of that, people follow very, I have no idea, but they do whatever the government do. If the government say people coming from high risk area have to show up and to go to quarantine, they are happy to show. And one of the things I think is most important, that the government have to pay for all that. If the government not pay for the quarantine, if the government not pay for the test, government not pay for the treatment, I don't think the people will follow that much. People will try to hide from the society police. They hide from the health system. But they know when they go to the health system, they are treated, they are being fitted, they are being tested, and they are being cared. And so far, you can see we keep number of cases at a small amount. We can keep no death. But if we have a high number of cases, we will have death. So everyone know that. Everyone know that if the number of cases increase, we will have death, and everyone follow. So
thank you.
I think that we are not very good at dealing with a huge outbreak. So we try to make it small.
Thank you so much. Dr. 𝐀𝐫 𝐅𝐨𝐬.
Thank you very much, Professor Romana. I'm aware of time, so I'll be very brief. I'm really pleased that in different kind of speakers, the balance between hardware and the software elements of the health system is being recognized. So that's something that I would like to also reinforce and perhaps set as a reminder. The world will never be the same again after COVID. So what will shape us is what we'll learn from this and where do we go from here. And I think one of the things that we can take as a lesson learned is our reflections on a whole range of capacities that are needed for the adequate dealing with epidemics. And from the kind of capacity perspective, I would like to briefly kind of emphasize that capacity is not just about individual skills and expertise, but it is also about organizational rules, systems, processes, as well as the wider environment. And in relation to Bangladesh, there is a lot of capacity that exists that can potentially be constrained by whatever is the kind of constraining environment. And the key is for the Bangladeshi health system to be able to unleash this huge potential, whether this is sort of enhanced role of civil society organizations and communities, or indeed very extensive network of community health workers, or indeed the technical expertise. So just from that perspective, don't look always outwards, see what exists and what you can use to the best possible extent. That's all from me, and back to you, Professor Romana.
Thank you so much. Dr. Khalida Islam.
Thank you so much, Professor Romana. I just would like to emphasize that along with COVID-19, we must ensure health care for non-communicable disease. We cannot let people suffer from this disease and develop more comorbidities. We need to find out ways how we will ensure this type of health care. We have to consider the context. We have to find out way forward, and we have to start thinking for ensuring non-communicable disease, chronic disease healthcare. Thank you so much.
Apologies, I'm also very conscious of time, but I would like to take just 1 minute of yours. That how do you see the involvement of the primary healthcare level workforce into this COVID situation? Just 1 minute. The workforce in the primary healthcare level. So your experience from the primary healthcare level engagement.
Actually, thank you. Actually, we have a huge workforce in the primary healthcare setting, frontline health worker who are the leader for bringing all the success. And for non-communicable disease situation, we are not utilizing them fully. We need to train them on how they have to deal with this, and we have to bring them under, as I said, under this electronic system, website system, web link system. We have to train them remotely, and we have to bring them so that through them we can reach the community, and they are the frontline health workers who will be able to bring the situation under control. Thank you.
Thank you so much. Dr. Jahangir. Just 1 minute, Dr. Jahangir.
Yeah, I think especially in Bangladesh, it's a really very difficult situation, and we don't know when we shall reach the peak there. But we still always in the problems, we have some solutions, and we have a lot of good examples around us, Vietnam, Cambodia, and many other countries.
It's 12 o'clock.
And I think government should follow those track and make the life easier for all people in the country. And of course, budget or funding commitment should be high, should take care of health professionals a lot, all those things. Thank you very much.
Thank you. Thank you everyone from my side for joining this webinar from different parts of Bangladesh and also from outside. So I now hand over to Advocate Soyed Mahbul Alam Tahin. Without his support, we could not arrange these webinars. So thank you so much, Tahin Bhai, for being with us, always extending your support. He is the true leader in the tobacco control in Bangladesh and also working for the health system for long. So Tahin Bhai, please summarize the discussion, and also if you have any points, please say, and you just conclude the session from your end. Thank you so much.
Thank you very much. First, I would like to thank all the presenters. We really learned a lot for Bangladesh. I just try to discuss, share some of the experience during the COVID situation. As a lawyer, we are trying to focus on the law and policy issue. As you know that in Bangladesh, there is one law, it's called the Communicable Disease Law. It's passed in 2018. So we try to find out that the government decision, what the decision taking, all the things that go by the law and other, it's not that. When we discuss about the health issue, mainly people are very much concerned about the health things, but all the things as you discuss about the lockdown, isolation and other things, mainly all the things are regulated by the law. So from our organization, Center for Law and Policy Affairs, we try to track all the policies, law and other things, how it happened. There is one of the study we recently released and found that one really the law is there, but in Bangladesh experience, most of the things are not happen according to the law. As per the law, the health department or the Director General Health Service should be in the main steering, but we think that we found that so many decisions taken without the consent from the health department. So many lockdown to the opening, the closing, and so many things are happening. That concern is not taken from the health ministry, and that is the one of the I think the big gap. In this system, as the Vietnam say that one, they have the steering committee. I think that in Bangladesh, we should establish a national health command, and that health command should be guided and led by the Director General of Health Service. And everyone should be followed there. In Bangladesh, in our study and when we review all the things, we found that so many good things has happened in Bangladesh government as a major developing country. We have so many welfare decision by the government, but it was not followed. I said that it was not a coordinated way and properly as part of the law. So many things are not happened. As discussed about the tracking and other things, that also initiated Bangladesh earlier, but it was not continued because it was not taken up by the Director General of Health Service. Our police department and local department, local government, and the local administration has very good initiative earlier, but it was not guided and well managed. So I think that when the COVID situation, when we are discussing, we have a law there, we have to follow that one. Besides that, some other like the Bangladesh and developed country, you know that there is so many challenges. Now the Bangladesh medical or healthcare is not only the public sector, there is a private sector, and there is so many lackings in the private sectors from side, and also like the medical business also is also hugely led by the private sector. So there is so many problems are facing from that of the oxygen and some other things. People are suffering due to the some greedy businessmen. So that should be also bring under the law. But the problem is that one still this law is not in the carrying, and people are not focusing on that one. I think that there is so many health advocates there. I urge all the people, we have to be follow the law. We have to be focused on the communicable disease law. And our findings show that one only the communicable disease law is not enough. There is several laws related to it. There is a Special Power Act, Consumer Act, and other things. There is a very interesting thing in the in Bangladesh. More than 12 writ petition filed in the High Court division during the COVID situation. Still, this is going on, and there is in the High Court division there is so many good decisions coming. But the problem is that one, as I say, that one, the command is not in the health directoral health service. So many things are they are taking decision, but this is the decision and implementation from the other ministry. So they are there is a delay process, there is a communication gap and other things. At the Vietnam say that there is steering committee, and under the steering committee, all ministry focal point is there. So this has helped to them take the quick decision. In Bangladesh, so many good decisions we found, but the problem is that one there's a lack of communication and other things. So our recommendation that in Bangladesh still we should have established a national health command, and that everyone should be follow this health command. Thank you very much to all people, and I again hand over the Romana to conclude that one. Thank you all the speakers. We learn a lot, and we honor that you join our program. Thank you very much, Romana.
Thank you. I'll just say again, thanks to everyone. Thanks to the panelists for joining and staying with us for 2 hours, though we said we will take 1 hour 30 minutes, but thank you so much for being with us. Thanks to all the participants who joined to the webinar, and also all the Facebook users who were with us. So thanks everyone. Hope to meet sometime soon. Thanks everyone. Thank you.
Thank you.
Thank you, everybody. Bye.
Thank you.
Bye.
Thank you. Bye-bye. Thank you.
Thank you very much. Thank you.
Thank you.
Bye.
Thank you.